My next question is how oncosurgeons and medical oncologists work together in a cancer patient?
Yeah, this is a very important and very relevant question actually. So it is not that when a patient comes to a surgical oncologist, first I say we operate. If it goes to a medical oncologist, first he says we'll give chemo. It is not like that. So, well, there are definite guidelines for each cancer, each stage, that this is the treatment that we have to do. Right now, it is all about individualization to take the patient's condition, requests, requirements, uh, and his comorbids, his status, a lot of things into consideration before considering the treatment. So every patient who comes with a cancer is ideally supposed to be discussed by a multidisciplinary tumor board, which to the least extent should have a surgical oncologist, a medical oncologist, and a radiation oncologist. For cancers like thyroid, we have a nuclear medicine and endocrinologist involved. For apart from these members in the team, it is ideal to have somebody who is from a social worker background, who is able to get the background of the patient and see what their cultural preferences are, what their financial status are. Putting all these factors and then discussing the patient's condition, stage, their ability, their age, their performance status to decide on the treatment is ideal. To give a small example, a young lady with advanced breast cancer, I want to be very aggressive and give all treatment. Whereas an elderly lady with the same advanced breast cancer who is hormone positive, there are guidelines to say to do less is more, and we have several patients who are doing well. So it is individualized to the patient, and it is very important that all of us keep our ego aside and think about the patient first and see what is best for the patient's interest and go for it. Would you like to add something?
Here I would just like to add an example or two for whatever sir said. Something like there are some cancers like early stage breast cancer or colorectal cancers, wherein initially to reduce the size of the tumor burden, if chemo is given for a determined number of few cycles, the tumor shrinks. So following which it becomes easy for the surgeon to operate on such cases, and following the surgery again we continue with the chemo. So it is not like that once there is a tumor or a mass, always it goes to the surgeon, or as he said, it should always come to the medical oncologist. It basically depends upon which is and what is best for the patient. Post discussion with the multidisciplinary team, we tailor make a plan what is right for the patient, and we follow that protocol.
How do we avoid getting cancers, and what are the screening tests for these common cancers?
So there is no one way to avoid cancers. There is nothing like that. It is like any disease, whether it is diabetes, metabolic disease. Our attempt to stay healthy, to eat healthy diet, to stay fit, to work out regularly, to keep a fit body, to make sure we get adequate sleep, we moderate everything and reduce our stress. All these parameters try to keep our immunity up. Our ability to repair ourselves is good. Thereby, we can reduce the chance of developing cancer. Avoiding habits which are known to be harmful, like oral tobacco, alcohol, smoking, all these definitely help in reducing the risk of cancer. But there is no particular food or there is no particular way to completely avoid cancer. That is not in anybody's control. Now, to talk about the screening test, I shall give it to Dr. Shivchand.
With regards to the screening test, anyhow, it is quite vast. We have something called as preventative screening test and diagnostic tests also cancer. Preventative are, for example, in breast cancers, we often advise patients to undergo periodic mammogram. If detected, if any lesion is detected, then it is radiologically graded. We have something called as precancerous, cancerous, highly suspicious, or less suspicious of. So in case if one such encounters one such lesion that is highly suspicious of malignancy, following which she can get tested by the physician, and if there is a cancer that is detected and in early stage, then the treatment rates as well as the outcomes are excellent. So similarly, we have for cervical cancer, we have a simple test called as pap smear, which probably will detect any early cancer or even pre-cancerous lesions. It's something like nipping of the thing at the level of bud is what we call. Such tests definitely have helped a lot in reducing the overall burden of the cancer patients, and on the advent of these tests, we are seeing a lot and lot of cancers being diagnosed at an early stage. Thereby, the therapeutic outcomes are quite good and best. Now, coming on to some of the advanced diagnostic techniques, chiefly to concentrate in this era of growing artificial intelligence and molecular screening and profiling, we have something called as next generation sequencing, wherein the patient's sample, tissue sample or the tumor sample is being checked for the mutational or the actionable genes that is present, and any targets that are identified, they can be treated. I mean, and if any drugs are identifiably matched with those targets, we do something called as targeted therapies. So thereby we have seen better outcomes in terms of probably better progression free survival or better disease free rates in such patients. And with the advent of a newer technique called as the liquid biopsy, wherein just with one patient sample, we blood sample, probably we are now at a position to tell the occurrence of the cancer in a patient even before the advent of it, or even if before the patient gets the sign of it or the symptom of it.
To add a point to this, see, there are certain screening protocols. Each country has its own screening protocol. We have a few screening protocols, but the widespread screening protocol that is followed is the pap smear, which is done for women routinely to detect cervix cancer early. Now everybody knows about mammogram also, and that is also routinely done. So the other screening protocols, usually unless there is a risk factor, it is not usually done for most of them. So what I would suggest is, when you go for your annual health checkup and you get your basic blood test like a CBC, RFT, LFT, it does not pick up any cancer at all. So if you feel you have done a yearly health checkup and everything is fine, I don't have a risk of cancer, then you are in the dark, you are mistaken. So you need to discuss with your doctor before doing your health checkup as to what are the tests that I need to do at my age. If you are 25 and you come to me, I would say don't do anything regarding cancer, because your chances are very low. But if you're 55 and you come to me, if you're a male, I'll do a different test. If you're a lady, I would do a different amount of tests, because that is the age where your risk of cancer is higher. So before doing a health checkup package, meet your doctor and say that there are certain tests I'm worried, and what are the common cancers that I have and what I need to screen for, and get those tests done. Those will be more useful. So,
to add up here, in case if there is a family history of breast cancer, we need to look in further if the other members in the family had any history of ovarian cancers, that is the blood relatives, and any history of ovarian cancers, of colonic cancers, which are all genetically linked. So in case of any one such history sounding positive, so they need to meet a genetic counselor, wherein a simple test is being done with which they can detect what the thing is, and probably further anything that's actionable can be carried out further, thereby preventing further occurrence.
So this is an interesting conversation about screening and how we decide on a patient's treatment. Thank you for asking us all those questions and helping the people get more awareness about it. Thank you.